Hello everyone. Welcome to ERMP and beyond. Today we will discuss one of the most frequently asked questions in medical exams among people living with HIV. To our case without further delay. A 42-year-old male known patient living with retroviral infection for the past 10 years, presented with abnormal body movement and left side body weakness of 1-day duration. He was admitted with an assessment of Toxoplasma cerebritis. His CD4 count is 60 cells at baseline and 80 cells currently. His viral load is 1200 copies per milliliter. His brain MRI showed ring-enhancing multiple cortical and basal ganglia lesions. What feature is suggestive of treatment failure in this patient? A. Low viral load. B. Toxoplasma cerebritis. C. Long duration. D. Low CD4 count. Welcome back to today's talk on a critical aspect of HIV treatment, understanding treatment failure. Now, let's dive into the complexities of this topic with a focus on three main types: virologic, immunologic, and clinical failure. Imagine a battle within the body where the goal is to suppress the enemy, the HIV virus, to undetectable levels. Virologic failure is when we can't keep the virus at bay below 200 copies per milliliter of blood, despite our best strategies. It's like the virus has slipped through our defenses. Even more concerning is when the viral load persists above 1,000 copies, not just once, but twice measured 3 months apart, despite all the support we provide to our patients to stick and to adhere to their antiretroviral therapy. Now, let's talk about the immune system's response. Immunologic failure occurs when, despite the virus being suppressed, the body's defenders, the CD4 T cells, don't rally as expected. We look for a rise in these cells by at least 25 to 50 units above the baseline, but sometimes, it just doesn't happen, or worse, their numbers drop from the highest count achieved. It's like expecting reinforcements that never arrive. Lastly, clinical failure is when new health battles arise, signaling that the treatment isn't holding the line. After 6 months of ART, if a patient faces new opportunistic infections or other HIV-related illnesses, except for the initial inflammatory response known as IRIS, it's a clear sign that the treatment plan needs reevaluation. This 42-year-old gentleman, a warrior in his battle against retroviral infection, comes to us with a perplexing set of symptoms. His body moves in ways he cannot control, and his left side shows a troubling weakness. Now, as we unpack this mystery, we must consider several factors that could suggest his treatment might be failing him. Let's explore option A. It presents us with a paradox, a low viral load, which usually heralds the success of antiretroviral therapy. Yet, in the twist of our tale, despite the low viral load, our patient's MRI reveals ring-enhancing lesions, a sign that all may not be well. It's a critical reminder that while viral load is a key marker in monitoring ART, it's not the definitive measure of success or failure. Moving on to option B, we encounter Toxoplasma cerebritis, an opportunistic villain that preys on the weakened defenses of the immune system. It's a signal, a red flag indicating that the patient's antiretroviral therapy might be losing the fight. Picture the MRI scan showing ring-enhancing lesions, a hallmark of this insidious infection, mirroring the struggles within our patient's case. It's a stark reminder of an immune system in jeopardy, potentially overwhelmed by the very treatment meant to protect it. Option C, we consider the duration of the patient's retroviral infection, known for a decade. While time alone isn't a definitive marker of treatment failure, it does contribute to the overall wear and tear on the immune system, making it more vulnerable to these opportunistic attackers. It's a subtle yet significant factor that we cannot overlook. Option D, the low CD4 count, a critical indicator of our patient's health. A count below 200 cells is a threshold, a line in the sand that, when crossed, signals a dire situation indicative of AIDS. Our patient's count has seen a slight increase, from 60 to 80 cells, but to truly understand the situation, we need consistency, repeated measurements to confirm persistence. Moreover, the patient's viral load remains unsuppressed, a silent alarm that all is not well. In light of these facts, option B stands out. Toxoplasma cerebritis is the most telling sign of treatment failure. Thanks for tuning in. I hope this breakdown helps you understand types of ARV treatment failures better. Don't forget to like, subscribe, and share. See you in the next video.